Good afternoon, and welcome to the Mayo Clinic's live webinar on ovarian cancer, titled What Women Need to Know About Ovarian Cancer. I'm Jamie Bakkum-Gamez. I'm one of the GYN or gynecologic oncologists at the Mayo Clinic in Rochester, Minnesota. And I'm joined today by Dr. Myra Wick, an obstetrician gynecologist and medical geneticist here at Mayo, and by Dr. John Weroha, a medical oncologist here at the Mayo Clinic. As an overview today, we're going to be talking about a wide variety of aspects of ovarian cancer. First of all, we're going to talk about how ovarian cancer is diagnosed and treated, what are the genetics of ovarian cancer, and how can the risk of ovarian cancer be reduced, and the importance of clinical trials in ovarian cancer, as well as the introduction of a novel Mayo Clinic ovarian cancer trial. I'm going to start off by going through an overview or an introduction to ovarian cancer. The objectives of my portion of the talk, or of today's webinar, are listed on the screen. And each one of us is going to have about 10 minutes to talk about each segment, each of the three segments in the broad overview. For this first portion, we're going to talk about the signs and symptoms of ovarian cancer, how ovarian cancer is diagnosed and treated, understanding the importance of your family history in understanding your risk of ovarian cancer, as well as understanding ovarian cancer prevention strategies. First of all, the first question is, how common is ovarian cancer? Here in the United States, there's about a 1.4% risk of developing ovarian cancer in any woman during their lifetime. This calculates out to about a 1 in 70 lifetime risk. However, there are women who are at higher risk for developing an ovarian cancer. Women with known mutation in two genes, BRCA1 and BRCA2, are at markedly elevated increased risk of developing ovarian cancer. Those with the BRCA1 gene mutation, the risk is about 35 to 60% of developing an ovarian cancer during their lifetime. Those with the BRCA2 gene mutation are at about a 10 to 30% lifetime risk. However, not all the genes associated with ovarian cancer are known, and there are some that are just recently emerging as elevated risk genes. What are some of the symptoms of ovarian cancer? Well, there happens to be a 4-symptom ovarian cancer index. These are bloating or abdominal bloating or increase in abdominal girth, pelvic or abdominal pain, difficulty eating or feeling full quickly when you first begin to eat, and frequent urination or other bladder changes. If any of these symptoms persist daily for 2 or more weeks, a woman should see her doctor for evaluation. When an ovarian cancer is suspected, the workup that your doctor or a gynecologic oncologist will go through is that of first a physical exam. Occasionally, a mass can be felt on a pelvic exam or an abdominal exam. There can also be evidence of increased abdominal fluid within the abdomen. A CA-125 level, which is a blood test, could be wrong, and that can go elevation, or if that is elevated, it's usually greater than 35, and this would be a suspicion. This would lead a physician to suspect that what they're finding on physical exam, that the symptoms that a woman is experiencing may be related to ovarian cancer. And usually there's imaging that's performed, whether it's a pelvic ultrasound or a CT scan of the abdomen and pelvis. All of these can give signs that may point to a diagnosis of ovarian cancer. When ovarian cancer is suspected or confirmed, treatment is a combination of surgery and chemotherapy. Most often, surgery is the first treatment, and that includes surgery to remove the uterus, the tubes and the ovaries, oftentimes removal of lymph nodes in the pelvis, as well as up along the aorta, the large vein and the large artery and vein that traverse the abdomen, removal of the omentum, which is a fatty apron of tissue that hangs down from the transverse colon and stomach. Oftentimes, however, with advanced ovarian cancer, surgery may require removal of a portion of the small or large intestine, removal of the spleen, stripping of the lining of the pelvis or the abdomen, which is called the peritoneum, removal of tumor from the diaphragm, removal of the appendix, and occasionally placement of a port inside the abdomen to receive chemotherapy. And Dr. Weroha will talk briefly about that a little bit later. The goal with an ovarian cancer surgery is to remove or debulk as much of the disease or cancer that is inside the abdomen of the pelvis in one setting. As you can see in this picture, these are the locations of some of the organs that are often removed in the process of debulking or removing ovarian cancer. The uterus, the ovaries, and the fallopian tubes. The pelvic lymph nodes travel along blood vessels in the pelvis, and then there's lymph nodes that travel along the aorta on both sides in the upper abdomen. In addition, where the omentum is located up in the upper abdomen, oftentimes this is also involved with cancer in the setting of ovarian cancer, and this is usually removed as well. This is all done through an incision that is up and down on the abdomen. And the reason that a large incision is almost always used is so that the surgeon can reach all of the disease in the pelvis as well as up in the upper abdomen. It's important when a woman is considering surgery for ovarian cancer that she understand what the goal is of the ovarian cancer surgery. In this graphic, you can see that there's an importance in removing as much tissue or as much cancerous tissue as possible. On the left-hand side of the graph in blue is NGR, and that means no gross residual tumor, meaning when the surgeon is done with the operation, they can't feel or see any residual cancer. These women are women that can have this achieved even in the setting of an advanced stage cancer, have improved survival compared to those who have a small amount remaining or even a bulky amount of tumor remaining. On the right-hand side, comparison of simple surgery, which is usually just a hysterectomy and removal of the tubes and ovaries, is not as superior as removal of all of the tumor that is there, which is most often performed in what we would consider a more radical surgery. So in the process of determining where to have surgery and who to have surgery with, one of the most important things that studies have shown from a surgical standpoint in the management of ovarian cancer is that gynecologic oncologists, when compared to a general gynecologist or general surgeon, appear to have improved rates of a comprehensive or complete surgery, higher rates of optimal debulking, meaning getting out more tissue, more cancerous tissue, and in some studies have actually shown that there's improved survival when surgery is performed by a gynecologic oncologist. Not only is ovarian cancer treated with surgery, but it is also treated most of the time with chemotherapy. And Dr. Weroha will talk more about this in a little bit. Surgery alone can be used in very rare situations when the cancer is confined to the ovary or ovaries and low grade, meaning it's a slow growing cancer. This is less than 10% of all ovarian cancers, which means that more than 90% of women with an ovarian cancer will also need chemotherapy. So how can we prevent ovarian cancer? And even more so, who's at higher risk for ovarian cancer? As I mentioned before, the average lifetime risk of ovarian cancer in the general population of women is about 1.4%. However, there are families and women who are at higher risk for ovarian cancer. In women who have developed an ovarian cancer, somewhere between 10 and 20% of them actually have a gene that put them at risk for developing the cancer and was causative of their cancer, whether it's BRCA1, BRCA2, or some of the other more recently identified genes. In addition, women with these genes are oftentimes also at elevated risk for breast cancer. And about 3% of women who are diagnosed with breast cancer have a gene that is a BRCA 1 or 2 mutation. So understanding your family history is extremely important, and Dr. Wick will speak to this in further detail in a short minute. What's important about understanding your risk of ovarian cancer if you're diagnosed with one of these genes, BRCA1 or BRCA2, is that your risk goes up with age. And as you can see in this graph, those with a BRCA1 mutation, which is in green, their risk starts to go up at a younger age than those with BRCA2 mutation. What I don't have on this graph is what the risk is if you don't have one of these mutations, and that basically is kind of a flat line of 1.4% throughout the lifetime. But that's also a gradual increase over time, but relatively flat compared to the BRCA1 and BRCA2 graph here. As you can see, BRCA1, the risk in women with BRCA1 mutations, the risk starts to go up around age 35 to 40, and that plays a role in when we recommend risk-reducing interventions. So what kind of risk-reducing measures can be done? This chart shows the risks of ovarian cancer based on several different interventions that have been shown over the course of several studies to actually reduce the risk of ovarian cancer. And this just happens to I'm using BRCA1 as an example here. If you look at the green arrow, this is the lifetime risk of developing an ovarian cancer in a BRCA1 carrier if no intervention is done, and that approaches 50%. However, there are surgical interventions that happen, whether they're for risk reduction or coincidentally performed, such as hysterectomy or tubal ligation, which are performed for usually clinically indicated reasons that are known and have been shown to reduce the risk of ovarian cancer not only in the BRCA carrier, but also in the general population. Having the fallopian tubes removed decreases the risk of ovarian cancer. Being on oral contraceptives for at least 5 years decreases the risk of ovarian cancer by about 50%. But the greatest risk reduction is seen in having the fallopian tubes and ovaries, which is called a salpingo-oophorectomy, removed, and the risk reduction is greater than 90%, with basically the ovarian cancer lifetime risk being reduced to nearly that of not having a mutation. So the care of the BRCA carrier is often multidisciplinary, as there are multiple risk-reducing strategies, including risk-reducing surgery. There's chemoprevention, which is another term for utilizing medications to reduce the risk of cancer, as well as screening and surveillance. The most important risk-reducing strategy, or the most beneficial risk-reducing strategy in preventing ovarian cancer and decreasing mortality from ovarian cancer, is that of removing both tubes and ovaries in a prophylactic fashion. RRSO means risk-reducing salpingo-oophorectomy. And there have been studies that have shown that this is highly acceptable, not only here in the United States, but also worldwide. There are high rates of risk-reducing surgery to prevent ovarian cancer in women who are at higher risk. And as you can see on the slide, the all-cause mortality is reduced by 77% when removing the tubes and ovaries for risk reduction. With that, I'm going to turn the mic over to Dr. Myra Wick, who's going to delve into further detail on the genetics of ovarian cancer.
Thank you. Dr. Bakkum-Gamez has introduced us a little bit to the genetics of ovarian cancer. In this next section, we're going to talk a little bit more about the genetics of ovarian cancer. We'll review some information about basic genetic testing. We'll look at the cancer risks that are associated with different hereditary cancer syndromes, and we'll talk a little bit about the cost of testing and some common insurance concerns that come up for patients who are doing some genetic testing. So let's look a little bit at the percentage of ovarian cancer that's actually hereditary. The vast majority of ovarian cancer is actually sporadic. Only approximately 10 to 20% of cases of ovarian cancer are actually due to a genetic cause or to a mutation in a gene, and we'll talk more about those hereditary causes. This pie chart here shows a distribution of genes in hereditary ovarian cancer. The highest percentage of hereditary ovarian cancers are due to mutations within the BRCA1 or BRCA2 genes, as Dr. Bakkum-Gamez has introduced us to. There's another hereditary cancer syndrome referred to as Lynch syndrome, and Lynch syndrome accounts for approximately 6% of hereditary ovarian cancer. The two most common cancers in Lynch syndrome are colorectal cancer and uterine or endometrial cancer. So those are two other cancers that we see frequently in Lynch syndrome. The other 34% of cases of hereditary ovarian cancer are due to other genes, and we're learning more and more about those genes almost on a daily basis. There are several laboratories that are now doing clinical testing for some of these genes, and we'll touch on that towards the end of my section. So let's take a look at what we typically see in a hereditary cancer family. On the left here is what we would expect to see in a family where there's a hereditary ovarian cancer or hereditary cancer syndrome. On the right is a family which is more descriptive of a sporadic ovarian cancer. So the things that are notable on the left-hand side, the hereditary side, we see multiple generations, so 1, 2, 3, of different cancers associated with the syndrome, so ovarian cancer, breast cancer, and you'll notice that each of these individuals is diagnosed at a relatively young age. In the sporadic case on the right-hand side, we see just this one patient here diagnosed at a later age. Very few other individuals in the family are affected with cancers. Now, not all families follow the rules of these pedigrees. So once in a while, we'll have families where it looks like a sporadic case, but when we go ahead and do testing, we actually find that there's a hereditary cause in a family like this. So that's the reason why we're now recommending that all patients with ovarian cancer be referred to a geneticist for further discussion of their family history and testing options. This is a picture of an individual's chromosomes. Chromosomes are little structures inside each of our cells that carry all of our genetic material. You'll notice here there are 46 chromosomes. Most individuals have 46 chromosomes. We have 22 pairs of non-sex chromosomes and then a pair of sex chromosomes. If we're female, we have 2 X's. If we're a male, we have an X and a Y. I have the locations of the BRCA1 and BRCA2 genes illustrated here. And one of the important concepts here is that BRCA1 and BRCA2 are not on the sex chromosomes. And so if an individual is carrying a mutation in the BRCA2 gene, she has a 50% chance of transmitting that to her offspring, whether that offspring is a male or a female. So BRCA1 and BRCA2 mutations can be inherited by both males and females and can be inherited from either your mother or your father. So those are important concepts that we don't always think about. Most of the hereditary cancer syndromes are inherited in what we call an autosomal dominant manner, and that's illustrated in the slide here. So here we have a mom and a dad. This is illustrating their pair of chromosomes. So we could say, for example, chromosome 17, where BRCA2 is located. This woman has 2 normal copies of the BRCA2 gene. The father has 1 normal copy and 1 copy of the gene with a mutation. So with each of his offspring, there's a 50% chance that he's going to pass along that mutation to that child. And so in a family of 4, we would expect 2 of the children to have inherited that mutation and 2 of them to not have inherited the mutation. Genetics doesn't always play fair, and so sometimes you'll see families where that proportion is off a little bit, but in general, this is the ratio that we would expect. All right, so let's talk a little bit about genetic testing. Again, recall that 10 to 20% of ovarian cancer is hereditary or caused by a mutation in a gene that was passed from one of the parents. Most of the time, we'll order a blood test. Some laboratories will use other specimens, such as a buccal swab, which is a cheek swab. In some situations, we can even use a skin biopsy specimen to do testing if we need to. The test is looking for mutations or errors, if you will, in specific genes. We can look at BRCA1 and 2. We can look at other genes, as we'll talk about in a little bit. Again, hereditary breast and ovarian cancer syndrome is due to mutations within the BRCA1 or BRCA2 genes. As we mentioned, approximately 60% of hereditary cases are due to mutations within one of these genes. We also talked a little bit about Lynch syndrome. Lynch syndrome, again, is more commonly associated with colorectal cancer, uterine cancer or endometrial cancer, and also ovarian cancer. It's a little bit more complicated in that there are 5 genes which are involved with Lynch syndrome. And again, Lynch syndrome accounts for approximately 6% of hereditary ovarian cancer cases. There are other genes that are also implicated. We're learning more about hereditary cancer genes associated with ovarian cancer. Very quickly, we're learning more about them. And there are laboratories that are offering cancer panel testing, and we're using those panels more and more frequently in the clinical setting. This just reviews hereditary breast and ovarian cancer syndrome, again, associated with BRCA 1 and 2 mutations. This lists the cancer here that is associated with hereditary breast and ovarian cancer syndrome, and then the risk that an individual with a BRCA1 mutation would have and a BRCA2 mutation. Several of these things we've talked about before. So an individual with a BRCA1 mutation has a 50 to 80% lifetime risk for breast cancer. BRCA2, approximately 40 to 60% risk. There's also an increased risk for contralateral breast cancer in BRCA1 and BRCA2 cancers. That means breast cancer in the other breast. Male breast cancer is one that we oftentimes don't think about, but BRCA1 and 2 carriers are at significantly increased risk for developing male breast cancer when compared to the general male population. In the general population, the risk that a male would develop breast cancer is much less than 1%. Ovarian cancer, we've already talked about the risks associated with that. Prostate cancer is another cancer that we think about for males who are carrying BRCA1 or BRCA2 mutations. And then there's a slightly increased risk for pancreatic cancer as well. There are different guidelines that we can use for screening and surveillance of individuals that are known to carry a BRCA1 or a BRCA2 mutation. We have specific guidelines for breast cancer screening and surveillance. You can look through these, but in general, we recommend self-breast awareness or self-breast exam beginning at age 18 for women who are carrying a mutation, clinical breast exam beginning at age 25 every 6 to 12 months, annual MRI between the ages of 25 and 29, and then an MRI and a mammogram every 6 months, alternating between the ages of 30 and 75. After the age of 75, we kind of leave it up to the discretion of the patient, the provider, to decide how often they want to do the imaging. We can also recommend medications that might help to reduce risk, including tamoxifen and raloxifene. With regard to ovarian cancer, we recommend risk-reducing bilateral salpingo-oophorectomy, as Dr. Bakkum-Gamez already talked about. She has talked about many of these things in the previous section, so I'm going to skip to the next screening section for male carriers. Males also need to undergo screening and surveillance, including self-breast exam beginning at age 35. They need to have a clinical breast exam by a provider beginning at age 35, and then a prostate exam beginning annually at age 40. We'll talk very quickly here about Lynch syndrome. Again, there are 5 genes involved. These are the main cancers associated with Lynch syndrome. The risk for individuals who are Lynch syndrome carriers compared to the population risk. So you can see there's a significantly elevated risk for colon cancer, uterine cancer, ovarian cancer, and stomach cancer in individuals with Lynch syndrome. We have screening and surveillance guidelines for Lynch syndrome as well. I'm just going to highlight a couple of these. One of the biggest changes between the general population and somebody with Lynch syndrome is colonoscopy. So in the general population, we recommend screening colonoscopy beginning at age 50 and repeating every 10 years if everything is normal. In an individual with Lynch syndrome, you can see that the colonoscopy frequency is every 1 to 2 years, so there's a significant difference there. We also have recommendations to screen for endometrial and ovarian cancer, including prophylactic hysterectomy and bilateral salpingo-oophorectomy, as we discussed for hereditary breast and ovarian cancer. There are also recommendations for gastric and small bowel cancer. There are other types of cancers associated with Lynch syndrome, but we don't have good screening and surveillance guidelines for those particular cancers, with the exception of urothelial, where we'll do an annual urine test. All right, let's talk a little bit about cancer panel testing. So in the past, we've gone through a patient's family history and then recommended BRCA 1 or 2 testing based on the patient's history and family history, and or Lynch syndrome testing. More recently, several laboratories are now offering cancer panel testing, which allow us to simultaneously test for approximately 25 genes at one time. This includes testing for BRCA 1 and 2, as well as all of the Lynch syndrome genes. There are about 19 or 20 additional genes included on these panels. Not all of the genes on the panel are considered to be high risk, and for some of the genes, we may not actually even have data about exactly what the risks are for some of the cancers associated with those genes. We may not have good screening and surveillance guidelines for some of the genes that are included on the panels. And sometimes we receive equivocal results that we don't really know how to interpret, and results that we don't follow up on a clinical basis. And we might see that in as many as 20 to 30% of people that are tested with one of these panels that includes 25 or more genes. All right, so wrapping up here, let's talk a little bit about cost and insurance concerns. Genetic testing is expensive. Oftentimes the cost of a panel will be around $4,000 to $5,000. The good news is that approximately 95% or more of patients with a personal history of ovarian cancer will have insurance coverage for genetic testing for ovarian cancer. And the reason for this is that it's considered to be a standard of care by many of our professional societies. Many of the laboratories will offer insurance prior authorization, so we'll know before we enter into the testing whether or not it'll be covered, and the patient is given the option to say no to the testing if the out-of-pocket cost is prohibitive for the patient. It's also important to be aware of the GINA law, which was passed in 2008. This is the Genetic Information Non-Discrimination Act, which protects against discrimination for health insurance and for employment if there is any genetic testing that has been done, or if the patient has a genetic syndrome. The GINA Act does not include life insurance or long-term care, so those are things that are important for people to think about before they proceed with genetic testing. With that, I'm going to turn it back over to my colleagues.
Thank you, Dr. Wick. Earlier, I talked a little bit about the fact that ovarian cancer is treated not only with surgery, but also with chemotherapy. Both of these are extremely important modalities in the treatment of an ovarian cancer. And I'm going to turn the mic over to Dr. John Weroha, who's going to talk about the importance of chemotherapy and clinical trials in ovarian cancer.
Thanks, Dr. Bakkum-Gamez. So over the next few minutes, I'm going to describe the role of chemotherapy after surgery. So you've already heard about the importance of surgery, and I'll talk to you about what's important to do after surgery if it's indicated. We will also talk about why we need to consider clinical trials and why it's important for you to think about clinical trials. And lastly, I'll talk to you about a clinical trial that is literally designed for you, which is a little different from any other clinical trial you've ever heard of, most likely. One of the questions I very commonly get in the clinic is, Dr. Bakkum-Gamez has already cut out the cancer. Why do I need chemotherapy? And what I tell patients is I think of cancer like dandelions. This time of year, there are lots of dandelions. And what you know is that if you pluck out 1, 2, or 3 dandelions, a week from now, there's going to be 3, 4 more dandelions. And the reason is because the seeds from those dandelions have already been sent out. And you can only pluck what you can see. And surgery is the same way. Our surgeons do an excellent job of getting out as much of the cancer as possible, but the seeds, so to speak, are things that we can't see and we can't pluck them out. And so that's where chemotherapy comes into play. The role of chemotherapy in this setting, when the cancer has already been cut out, is to try to kill those seeds and prevent them from ever coming back. And the other thing I tell patients is you've just had a really big surgery, and this is your chance for cure. And not many patients, or not as many patients as we would like to have walk through our doors, are able to hear those words that we are trying for a cure. And so when it comes to something big like surgery followed by chemotherapy, it is a big time commitment. But remember, what we're trying to achieve here is cure. What you need to know about chemotherapy is that one of the drugs will almost always be what we call a platinum, whether it be cisplatin or carboplatin. This is the backbone of our chemotherapy regimen. It's usually paired with another chemotherapy, for example, paclitaxel, or Taxol is the other name for that drug. These drugs can be given two different ways, and so you'll have to talk with your oncologist as far as the pros and cons of each approach. I would say that it's most often given intravenously or in the veins, but the other way to give it is directly into the abdomen. And this is what you heard earlier, is that a part of your surgery could involve a port placement, and that port placement would allow us to give chemotherapy directly into the abdomen. And again, you'd have to talk with your medical oncologist or your GYN oncologist about the pros and cons of each approach and go with what you think is best for you. The other thing that's important to think about is that we like to start chemotherapy fairly soon after surgery. We're talking about 3 or 4 weeks after surgery. And for some patients, they're a little worried that they might not be ready. And I would say most patients are ready by then. A lot of patients want to plan life, go to work if they can, and go on vacations and that sort of thing. And so they often ask, how long am I going to be on chemotherapy? And in general, plan for about 18 weeks. There may be some extra weeks in there. It just depends on how chemotherapy goes, but roughly it's going to be about 18 weeks. So this graph is meant to just show you why we really need to think about clinical trials. What you've already heard is that ovarian cancer has a survival timeline that can be improved. And what you see here is, if this circle represents all women who are diagnosed with ovarian cancer at the time that they have surgery, and then they go through their chemotherapy, by the time they end their primary treatment with surgery and chemotherapy, a fraction of those patients still have cancer that's residual. But most of those patients will have a good response to treatment, meaning at the end of their treatment, there's no visible evidence of cancer, which is what's depicted here in orange. But unfortunately, as time goes on and we follow these patients closely over the next several years, what we see is the patients who initially had a good response to treatment, no evidence of disease at the end of chemotherapy and surgery, will have a recurrence of their disease. So if we go out 5 years, the proportion of women who are still living without cancer is a lot smaller than we would like. And what we know is that we need to improve our therapies. The therapies we have currently are not good enough. And we owe it to our patients to do better. And as a clinician, our patients come to us with questions, and they come to us ultimately looking for hope. And we as clinicians turn to research, turn to clinical trials to try to find the answers to those questions and also develop the hope. The most important thing I think patients need to understand is that the standard of care for a patient who has recurrent ovarian cancer really should be a clinical trial. And I think this is important to point out. Several patients said to me, as soon as I mentioned a clinical trial, they said, oh, I thought a clinical trial was something patients only did when they had no other options. And that's actually the opposite. A clinical trial is what you should do when you're strong enough for it, and when you're able to travel, and it is a way for you to maximize your options. Because off-the-shelf chemotherapies are always going to be there. They're not going anywhere. You can use them anytime. But clinical trials open and close all the time. And so if you really wanted to expand your options and keep the most available options on the table, you should really consider a clinical trial as early as possible in your care. Along those lines, there are a few misconceptions about clinical trials. This is the first one that I have listed here in that, clinical trials, one myth is that you use it when you have no other options, but in reality, it increases your options by doing a clinical trial. And again, some patients say, well, I can always do a clinical trial later, right? And actually, sometimes you can't. A lot of our clinical trials will exclude patients if you've had too many treatments. Some of these trials will also exclude patients if you're not strong enough. And the other thing, as I mentioned, is these trials open and close all the time. So it's not true that you can always do a clinical trial later. And the next question is that I get oftentimes is, I don't want to do a clinical trial because I'm going to get a placebo. And actually, that's not true most of the time. In fact, very few of our trials will have a placebo arm to them. The thing to remember is that whatever trial you go onto, you must get at least a standard of care. And so if the standard of care is to give you a chemotherapy, then you must get some sort of therapy, and you would not get a placebo. So keep that in mind. Another comment that I've had is I like the idea of clinical trials. I mean, it helps other people, but it really doesn't help me. And what I would encourage you to keep in mind, though, is that if you were seeing me, I would look for a clinical trial that makes sense for you, one that uses a drug that should have activity in your cancer. And so I would specifically be looking for a trial that really should help you, in addition to helping the other people that would come after you. A very common question or a very common concern is that insurance will not pay for a clinical trial. And this is actually not a myth, it's actually true. But what you have to also keep in mind is that you won't pay for the clinical trial either. The things that your insurance should pay for are the things that are considered standard: blood tests, CT scans, follow-up visits. All of those things are covered by insurance or should be covered by insurance. The things that won't be covered by insurance are, for example, extra biopsies that are required for the clinical trial or the drug itself for the clinical trial. But all of those things will be covered by the trial in some way, and that expense will not come to you. The last thing I wanted to talk about, continuing with the idea of clinical trials and what clinical trials can do for you, we have a clinical trial at Mayo that is specifically designed for our patients. And the problem, the idea behind this trial really began with the problem. And the problem is we have a hard time as clinicians predicting which chemotherapies will work for which patients. And so essentially when I see a patient, I go through the different chemotherapies that are available. I talk about the side effects. I talk about the schedule of treatment. And we basically decide which one the patient prefers, which one I prefer. But there's really no way to predict who responds to what. The clinical trial that we are about to open at Mayo Clinic will change all of that. The hope and the idea behind this trial is that we can predict which chemotherapy will work best for you. And essentially what we are making are ovarian cancer avatars. We also call them OVATARs, for ovarian cancer avatars. And in this trial, patients who have their surgery at Mayo Clinic with colleagues like Dr. Bakkum-Gamez will have a piece of that tumor taken and put into a mouse to make an avatar. And when you think about the definition of an avatar, according to the Oxford Dictionary, it's an incarnation or manifestation of a person. And that's essentially what we're doing with these tumors as we're putting them into mice. We get them to grow in mice. These are also called patient-derived xenografts or tumor grafts, as I'm sure you'll Google about it, and these are the terms that will be used. And once we do this, what we can do is put them into as many mice as we need to start treating them with chemotherapy. And in fact, we would then treat these mice with the chemotherapies that women use as second-line therapies. This includes topotecan, paclitaxel, liposomal doxorubicin, gemcitabine. We can even do other drugs if we wanted to, but for now, this is what we've got on the trial. In parallel, what's happening with our patients, they've had their surgery, they've had their chemotherapy that I've already talked about, and then they go into observation. And if the cancer ever comes back, and we hope it never does, but if it does, and the patient still has a platinum-sensitive tumor, which means your oncologist thinks that platinum might still work, you wouldn't start the clinical trial yet. What you would do is you would probably get more platinum again, and this is at the discretion of your treating oncologist. But once you got to the point where the tumor was platinum resistant, you would then be offered one of these chemotherapies. But rather than picking a chemotherapy at random or based on my preference or your preference, we would do it based on how the tumor was killed in the avatar or in the mouse. And so we can direct your therapy based on data that actually impacts you. There are a few key things to remember here, and it's a little bit of this is a plug to have your surgery done with our colleagues, not just because they're good, but also because this trial requires you to have the surgery done at one of the Mayo sites, Minnesota, Florida, and Arizona. But after you have the surgery, you have to make sure you keep in contact with us. We have to know if the cancer comes back, and then we can tell you whether or not we have an avatar for you. And if the cancer ever recurs, we could help direct your therapy. And we hope that we never have to see you again. But if we do, we might have something to help you. And the key thing about this clinical trial is that it's avatar-directed therapy, and it's just for you. The other thing that's also a key feature here is that you can do all of your chemotherapy at home because these are standard therapies. We can tell you which therapy to take, and then you can go home and do it with your oncologist there. A lot of patients really, really appreciate that. The other thing is that all of these drugs have very well-known side effects. So it's not like other clinical trials where you're taking a drug and we don't know what the side effects are. All of these have very known side effects. So in summary, what you've heard over the last 40 minutes is that ovarian cancer is treated with a combination of surgery and chemotherapy, and that women have a better survival if the surgery is done by a gynecologic oncologist. You've heard that there are certain mutations in genes such as BRCA1 and 2, which can increase the risk of developing ovarian cancer as well as several other cancers, and that there are several ovarian cancer risk-reducing strategies that we can offer our patients to reduce the chance that the ovarian cancer will ever develop. Clinical trials, again, really should be offered early on in the care of our patients and not considered as something that's late in their care. And also keep in mind, we have a very unique clinical trial opening soon here at Mayo that isn't happening anywhere else, and you've really got to do it here. The last thing I will say is that I want to make sure that we thank our patients because they are the ones that make these clinical trials happen, and we couldn't do it without them. And it's an honor to be a part of their journey from cancer diagnosis through cancer treatment.
All right. Thank you, Dr. Weroha, and thank you, Dr. Wick. We're going to shortly open up the lines for live question and answer with all three of us. I want to echo what Dr. Weroha said early on, and that is that we hope for a cure. We're aggressive with surgery and chemotherapy. We're also aggressive with understanding the risks within families in order to identify women who are at higher risk in order to try to reduce mortality from ovarian cancer. And as an oncologist, it's one of the best things to be able to say to a patient, I really do hope I never see it. That is a wonderful feeling if we can provide a cure for our patients. So moving on with the live question and answer. We're going to be fielding some questions here that our viewers have entered, and feel free to add additional questions. Do I scroll down? Sorry for the short delay here. All right. So, first question, just had the finding of BRCA2 variant of uncertain significance. Testing in the parent is pending. I'm not sure on the clear implications for surveillance for my daughters. They were ages 27 and 29, beyond birth control pills, given that the variant of uncertain significance. Dr. Wick, what do you think about this?
That is an excellent question. So variants of unknown significance are typically thought of as being not clinically actionable. So we usually don't make recommendations about special screening and surveillance in that situation. We want to make sure that we're in very close contact with the laboratory and different databases to make sure that there haven't been any updates in the status of the VUS. Oftentimes the laboratories will contact us directly and let us know if there's been a change in the status, and then we will act on that depending upon what the new status of that VUS is. That's a very common problem or situation, especially when we do the panel testing. We are finding a lot of variants, and we're working very hard to try to understand more about the variants and have those reclassified so that we can help families with screening and surveillance.
Thank you, Dr. Wick. Moving on to the next question. Is there a cure for ovarian cancer stage 3? We've had 6 courses of chemotherapy. Dr. Weroha, would you like to field this question?
So I think part of that question also said there were maybe 2 courses of, was it 2 courses of 6 cycles?
I think it was 6 cycles.
6 cycles total. So I think if it, it sounds like a question about adjuvant chemotherapy, being chemotherapy given right after surgery. And again, we're shooting for cure in this case. And stage 3C is the most common stage that we see. We see a lot of it. And I would still say that there is a chance for a cure there, and I would be very aggressive with the chemotherapy.
Excellent. Next question. What if I didn't have my surgery at Mayo, but my tumor was tested through Caris? Could I still do the AVATAR trial? And I'm going to turn this one back over to you, Dr. Weroha.
Yeah, it's a good question. So, Caris is a test that we sometimes use, and for the audience out there who don't know about Caris, it's a company that will try to predict response to chemotherapy based on some mutation testing, but a lot of staining of the tumor to look for what proteins are being expressed. And then they can try to extrapolate from that staining profile whether or not a tumor is going to be killed by any particular chemotherapy. So the answer to the question, though, is no. To participate in the AVATAR trial, you have to have your surgery done here at Mayo. We have to collect that tumor, and we have to make an AVATAR at the time of your surgery. The key part of it is that the tumor has to be alive and it has to be fresh, and within minutes of being resected, we're trying to get it into mice. So we can't do it on old tissue that's archived.
All right. Well, moving on to another question. I think one question that I hear asked of me quite frequently as a GYN oncologist is, when I get chemotherapy, am I going to lose my hair?
That's a really common question. And for most patients, the answer is going to be yes, but it depends on the type of chemotherapy. So the chemotherapy that is most associated with hair loss is going to be paclitaxel. And so every patient who's getting chemotherapy after surgery is probably going to get paclitaxel. So for those patients, yes. In the recurrent setting, when patients are getting other chemotherapies, the hair loss is much less. But I always tell patients it's temporary. It will grow back. Sometimes it grows back a different color. Sometimes it grows back curly if it used to be straight, but it will grow back.
Thank you. All right, so next question. Do my sons or brothers need to worry about BRCA1 or BRCA2? Dr. Wick, you talked a little bit about the fact that this is not an X-linked or Y-linked chromosome. These are not X or Y-linked chromosome genes. Can you talk a little bit more about that?
Right, yeah. So BRCA1 and BRCA2 can be transmitted from either a male or a female, to both sons and daughters. So the answer is yes, your sons and your brothers do need to be worried about BRCA 1 and 2. Some of the cancer risks in males include male breast cancer and prostate cancer. So we have specific screening and surveillance guidelines for men who are BRCA 1 and 2 carriers. And men can also transmit BRCA 1 and 2 to their sons and daughters. So they do need to be aware and be doing screening and surveillance if they are carriers.
Okay, excellent. Another thought-provoking question here. What is the youngest age that you recommend genetic testing for young women, notably 15-year-old, whose paternal grandmother died from ovarian cancer?
All right, that's a great question, and there are several questions actually embedded in there. So the first question would be, did the grandmother have genetic testing? Do we know what the mutation is in this particular family? If we're testing individuals who haven't had cancer, that leaves a lot of unanswered questions and questions about whether or not we should even be testing unaffected individuals. The second question would be, if there is a mutation that was identified in the paternal grandmother, has the dad been tested? Do we know whether or not he's a carrier? So if he is not a carrier, and we know there's a BRCA mutation in the family, then we don't need to ever test his daughter, because if he doesn't have the mutation, he can't pass it along to his daughter or the granddaughter of the woman with ovarian cancer. And then finally, usually for adult onset disorders, we recommend that we wait to do genetic testing until the patient is 18 years of age or of legal age, just so that we can make absolute certain that that patient actually wants to do the testing, that they're not getting pressure from family members, and that they can also understand what the implications are. So in this case, we wouldn't do any screening or surveillance before age 18, so we don't really see a good reason to test for that mutation before age 18.
Excellent, thank you. Moving on to the next question, how can I distinguish symptoms of ovarian cancer from possible gastrointestinal conditions, especially when there's similar symptoms? I've been told that ovarian cancer is sometimes misdiagnosed as a gastrointestinal disorder. I would say this is actually quite true. There are studies that have shown that the delay in the onset of symptoms in ovarian cancer and the diagnosis is oftentimes about 6 months. Distinguishing the symptoms of ovarian cancer from GI conditions can be quite challenging, because the symptoms of ovarian cancer can be vague and they can mimic other disorders. Most important thing to understand is that if you have these symptoms, if you have the symptoms of bloating, abdominal distension, GI changes, bladder changes, appetite or ability to eat changes, to be seen by your doctor. Imaging can help to distinguish between whether this is something GI or not, meaning a CT scan or an ultrasound. Sometimes patients with ovarian cancer have a GI workup first before they're actually found to have the ovarian cancer. Sometimes that includes having a colonoscopy or an EGD. It all depends on what your primary care or primary care provider or the physician working you up does in the process of the workup. But it is important that if symptoms persist or change, that you be seen again for further evaluation. Moving on, can we talk a little bit about vaccine clinical trials? And I think I'll ask Dr. Weroha to field this one.
Yeah, so there are vaccine clinical trials, and what you have to keep in mind is that a vaccine requires that your immune system recognize a protein that is unique to the tumor, and that allows your immune system to then attack that tumor and kill the tumor. We have an interest here in a couple of proteins that appear to be very unique to ovarian cancer. One is the folate receptor, and this protein is one that's preferentially expressed on ovarian tumors, but really not anywhere else in your body. Another protein is one called NY-ESO1. You don't have to try to remember that, but to know that it's actually a testicular protein. And so again, it's not one that's expressed or it's not one that's present in the rest of your body. And we do have trials that try to exploit that. So basically, these ovarian tumors have a protein on them that really isn't anywhere else, and we are trying to teach your immune system how to recognize and kill that. We can go into more details if there are specific questions on the blog. I can certainly try to answer those after the session is over.
Excellent. Thank you, Dr. Weroha. We have time for just a couple more questions, and so we're going to move forward with a very important question for Dr. Wick, and that is, do men get the BRCA 1 and 2 genetic testing if their mother had ovarian cancer, but she didn't have genetic testing done?
Another great question. Yeah. So again, we always get the most information for a family if we can test somebody who's actually been affected with one of the cancers associated with that syndrome. In some families, we don't have that option. Maybe everybody who's been affected with cancer has passed away, or sometimes people don't want to do genetic testing. And so sometimes in that situation, we will test the next person in line, if you will. It's important to understand the limitations. If we have a negative test result, that doesn't mean that we've ruled out a BRCA mutation in that family, and we may not have ruled out, we certainly haven't ruled out the possibility that there might be another cancer gene involved in that family. Sometimes there can be issues with insurance too, getting the insurance company to cover the cost of testing in this situation. But in the appropriate situations, the answer is yes, we will try to work with you to do the appropriate testing in that family situation.
Thank you. So I think we'll come down to our last question of the webinar session. And that one is, are there other clinical studies available if surgery was done elsewhere? It's kind of a two-part question. Or could a second surgery qualify me for an Avatar, for the Avatar clinical trial?
So the answer to the first part of the question, whether or not there are clinical trials available if you had your surgery done elsewhere, the answer is absolutely yes. I think part of the problem that we have sometimes is we have so many clinical trials, you actually have a lot of options, which is a good problem to have. But also the second part of the question, could you still be a part of an Avatar trial? Not the Avatar trial that I spoke about, but there is a clinical trial going on right now where if you participate in this trial, we do make an Avatar. The catch here is, though, this Avatar would not guide your therapy. It would be used to better understand why the therapy worked or didn't work, and we would be doing those tests on the Avatar.
All right. Thank you, Dr. Weroha. I want to thank everybody who's tuned in and everybody who will be viewing this at a later time. I want to thank you for your time. We'll try to answer any additional questions that we didn't get to in this session during the following week. And as other questions come up while you're viewing the webinar and reviewing what we've spoken about today, feel free to continue to send us questions and we will field them as possible, as soon as possible. Thank you.